Today we are going to study about tetratology of fallot, which is very important topic. So tetratology of fallot, as we know, it is a congenital heart disorder of infants. So the components of tetratology of fallot are overriding of aorta, right ventricular hypertrophy, ventricular septal defect, and subpulmonary stenosis. So these are all the four which are the components of tetratology of fallot. Now, as we know that in tetratology of fallot, what happens is that there is right ventricular outflow tract obstruction. Means if this is right ventricle, so there is subpulmonary stenosis, which will lead to obstruction to the flow of blood to the pulmonary artery. As the obstruction will be continued, what will happen? To overcome that, right ventricular hypertrophy will occur. Now, as we know that there is also a ventricular septal defect, that is VSD, which is present between right ventricle and left ventricle. So the flow of blood will occur from right ventricle to the left ventricle, as there is obstruction to the blood flow, that is right ventricular outflow tract obstruction, which will lead to decreased oxygenation, and oxygenation means flow to the blood flow to the lung will be diminished, or it will be decreased, and it will result in cyanosis. So this was about the tetratology of fallot. Now there is also pentology of fallot. In pentology of fallot, the components are tetratology of fallot, means all the four components, there's all four components, plus atrial septal defect will also be there. Similarly, there is triology of fallot, in which there is atrial septal defect, right ventricular hypertrophy, and pulmonary stenosis. Now, what are the consequences of the tetratology of fallot? So, as we know that tetratology of fallot is a cyanotic congenital heart disease, so it will cause cyanosis, and it will also cause failure to thrive, and also single second heart sound will be heard, means only A2 component of the second heart sound will be heard, P2 component will not be heard. And in pulmonary area there will be ejection systolic murmur, and also there will be no ventricular systolic murmur, means VSD murmur will not be there. Why it will not be there? Because the defect, that VSD will be large, and there will be less turbulence to the flow of the blood from right ventricle to left ventricle. So ventricular septal defect murmur will not be present. Now, what are the complications of the tetratology of fallot? Tetratology of fallot can cause infective endocarditis. Now the complications can be learned as, like, there is polycythemia, means RBC amount will be increased. So as RBC amount will be increased, viscosity will be increased. So increased viscosity can lead to thrombosis. This thrombosis, when it detaches from its original site, will lead to the formation of emboli, which will be paradoxical emboli. Now this emboli, when it detaches and when it via blood flow, when it goes to the brain, it will lead to brain abscess. And also one more consequence is there, hypercyanotic spell, which is very important. It is also known as TET spell. So we will study about it in another video, but it is very important. Now what is the treatment of tetratology of fallot? So tetratology of fallot, the treatment is either it can be definitive or it can be palliative treatment. So in definitive treatment, as we know that early diagnosis is the key. So if the surgery is done within 3 months, the consequences are very good, means the survival rate and development of complication, survival rate will be very high, and development of complication will be low. Now in palliative treatment, shunt surgeries are performed, like, as we know that the blood flow from right ventricular to pulmonary artery is being obstructed. So as the blood flow from right ventricular to pulmonary artery is being obstructed, we will shunt various arteries with pulmonary artery to increase the blood flow of the pulmonary artery, so that cyanosis will not develop. So there are various surgeries which are being performed, like classic Balalock shunt, in which we shunt subclavian artery to the pulmonary artery directly, such that the subclavian artery blood will flow to the pulmonary artery and the oxygenation will be increased. Now, modified Bellalox shunt, it is also most commonly done. It is the most commonly done, and here also we shunt the subclavian with pulmonary artery, but here we use a conduit. Now, Watterson shunt, in which we shunt the ascending aorta with the pulmonary artery, and similarly Potts shunt, in which we shunt the descending aorta with the pulmonary artery.